Ladies and gentlemen, please welcome Grantmakers in Health President and Chief Executive Officer, Kara James.
Thank you, and good afternoon, and welcome to our final plenary session of the first day of our 2021 annual conference. Our session today will focus on federal opportunities to improve health and healthcare. As you all know, we are a little more than 4 months into a new administration. There has been a lot of attention and opportunity to address a number of issues related to the pandemic, rebuilding our public health infrastructure, expanding coverage options, and making sure that we're addressing the social determinants of health to ensure that we are making sure that everyone can achieve their highest level of health. In our conversation today, I am joined by two experts who themselves have experience working in the government and are also working in the nonprofit and philanthropic space to help talk through what some of those opportunities are. So I'm pleased to welcome first David Blumenthal, who is the president of the Commonwealth Fund. Prior to joining the fund in 2013, he was the Samuel Thier Professor of Medicine at Harvard Medical School and Chief Health Information and Innovation Officer at Partners Healthcare System in Boston. We also will be joined by J. Nadine Gracia, who is the Executive Vice President and Chief Operating Officer at Trust for America's Health, where she works in partnership with the President and CEO to develop and implement strategies, policy priorities, and manages TIFA's core business functions and internal operations. Should also say that she and I worked together when she was at the Department of Health and Human Services, and I am very much looking forward to the conversation with both of them. We're going to start with a little bit of an overview from each of them from their perspective on what some of the challenges and opportunities are, and then we will launch into a discussion. Please go ahead and start chatting your questions into the conversation, and we'll incorporate those as we move along. So without further ado, I'm going to turn it over to David, who will kick us off.
Thank you so much, Kara. It's a pleasure to be here, a pleasure to be together with all my colleagues from the philanthropic community. I'm going to say a couple of things about the Commonwealth Fund, and then a very brief overview of what has transpired in those 4 months since the new administration took over. These have been really historic times for quite a number of reasons, and I think I'll be able to illustrate why. So first, just a couple of words about the Commonwealth Fund. We are an independent, nonpartisan think and do tank that was founded in 1918 as a private philanthropy. Our mission is to achieve a high-performing health system that provides affordable and quality care for all Americans, with a special focus on our most vulnerable individuals, people of color, and people with low income. We give away about 35, or have a budget of about $35 to $40 million a year, closer recently to 40 because of the good fortune we've all had, I think, in the marketplace recently. So I don't think it's fully recognized what an historic moment we are witnessing with respect to healthcare. And there are several components to this agenda that President Biden has launched. And I know I wasn't personally aware of it until I began looking at the legislation and the budget that he has introduced. So many of you are familiar with the fact that the American Rescue Plan has already passed. It had major public health and anti-COVID investments, but it also included expansions of coverage in the form of more generous premium subsidies under the Affordable Care Act, efforts to expand Medicaid through increased federal matching funds, and even subsidies for private insurance among people who recently given up their private insurance because they've left their place of employment. He's also proposing something called the American Family Plan, which would further increase ACA subsidies. Also includes a really historic attack on social determinants of healthcare, what we would call those social determinants of healthcare, having to do with education expansion, childcare expansion, mental health expansion, homelessness assistance, and more. This is not your typical federal legislation. If you look at his budget, it is in some ways even more impressive. Now, budgets don't make legislation, but they indicate intent. And this is the president and his administration's intent to dramatically expand home and community-based services, to regulate drug price controls in ways that have never been done before, to institute a public option, though whether that's practical, we'll be discussing later, and then to get to the 4 million Americans who would be eligible for health insurance through Medicaid if non-expansion states, the 14 of them, were to expand Medicaid. Finding ways to close that Medicaid gap is also part of the Biden budget. So I'll stop there and turn things over to Nadine.
Thank you, David. Nadine?
Kara, and greetings, everyone. It's such a pleasure to be here with all of you in the Grantmakers in Health Annual Conference and to join my colleagues Kara and David for this important conversation and discussion. Again, my name is Nadine Gracia, and I'm the Executive Vice President and Chief Operating Officer at Trust for America's Health. And similar to David, I'll describe a little bit about our organization and then talk about some of the opportunities. David did a wonderful job in speaking to President Biden's budget, and I'll speak to some key priorities in particular that we at Trust for America's Health are advocating for. So first, just to share a little bit about Trust for America's Health, our organization is in its 20th year. We are a nonprofit, nonpartisan public health policy research and advocacy organization that's headquartered in Washington, D.C. And our mission is to promote optimal health for every person and community, and where we make the prevention of illness and injury a national priority. Our vision is that prevention and health equity are foundational to policymaking at all levels of society. Our primary audience are federal policymakers. We advocate to Congress and educate members of Congress and their staff on key public health priorities, as well as the administration and federal executive branch agencies. Some of the ways in which we engage in our work is certainly in advocating and advancing a strong and effective public health system. And I know that we'll be speaking to that, and there are sessions throughout this conference speaking to the importance of the public health system, which we certainly understand and have a greater attention to with regards to the context of the COVID-19 pandemic. We also issue reports that are evidence-based reports rendering policy recommendations that are data-informed on a host of key policy priorities, such as public health funding, public health emergency preparedness, obesity prevention, substance misuse and suicide prevention, and healthy aging. We host various convenings, bringing together policy experts, stakeholders from around the country, community advocates, national organizations, and those with lived experiences to really look at some of the leading public health issues, as well as emerging public health issues, so that we can formulate recommendations and guidance to policymakers on key and core issues facing the nation with regards to health and well-being. And lastly, we also work to foster a national dialogue, utilizing traditional and social media, various communications mechanisms to be able to address key public health priorities. The way in which we do our work, we are entirely funded through philanthropy and foundations. And so we work really in partnership with our funders on a whole host of these areas to advance key public health priorities. In speaking about some of the opportunities, and David certainly outlined some of the ways in which the American Rescue Plan and the President's budget are really addressing some of the critical areas for the nation as it relates to health and healthcare. For Trust for America's Health as an organization that focuses on public health and prevention, we certainly see one the key opportunities is certainly in advancing a modern public health system to really meet the public health threats and public health needs of the 21st century. I know we're going to just talk about this more during our conversation today, but that really means ensuring that we increase and sustain funding for the public health infrastructure, inclusive of a well-trained workforce, as well as state-of-the-art data. And we have all seen some of the data challenges, certainly in the context of this pandemic, as well as utilizing evidence-based approaches and a focus on key health issues. And we see through the American Rescue Plan, as well as through the President's fiscal year 2022 budget, really dedicated investments into public health infrastructure. And what we can do beyond that really is critical as well. Secondly, is certainly addressing the structural drivers of health, including the social, economic, and environmental conditions. The graphic that you see here is a graphic that just shows, in particular, how we focus on addressing community conditions, often referred to as the social determinants of health, where as you go further downstream, focusing on individual needs and the importance, for example, of the healthcare sector in addressing clinical needs and individual patient needs. Where we focus at Trust for America's Health is also further upstream, really addressing community conditions through laws, regulations, and policies to create the community conditions that will promote health. Lastly, we also see as a great opportunity is advancing health equity by certainly addressing policies and practices, institutions, and systems that really are at the root of health disparities, addressing certainly structural racism, poverty, discrimination, and other inequitable policies and practices that really have been at the root of these health disparities for far too long, and creating equitable systems and opportunities for health so that everyone has a fair and just opportunity to reach their full potential for health. So I look forward to the conversation this afternoon, and I'll turn it back over to Kara.
Thank you, Nadine. Thank you, David. So we have an ambitious agenda that we're going to try and make our way through over the course of the next few minutes. And again, want to encourage people to send their questions in. But I thought I would just start. I purposely didn't talk about your experience in government in my introduction, but wanted to just kind of give you a moment to maybe tell a little bit about what your experience has been and where you worked and what you were working on during your time. And I know you both had multiple courses there. So maybe I'll start with you, David.
Sure. Thank you. My career, I trained as a physician, but I've always considered myself a health policy analyst and health policy participant. I actually began my formal public service working on Capitol Hill for the late Senator Edward Kennedy as a professional staff member. Spent several years there. Then did research and writing on healthcare policy, and then found myself working for multiple presidential campaigns, the campaigns of Michael Dukakis, John Kerry, and then ultimately President Obama. And it was that last involvement that led me to a role as that I didn't anticipate and probably was not qualified for, and that was to be the national coordinator for health information technology at the beginning of the HITECH Act, and with the mission of wiring the delivery system, not the public health system, but the delivery system in the United States. So those were the roles I've played. They've been all in their own ways extremely gratifying, rewarding, educational, eye-opening, and just a great privilege to have been involved in.
Thank you. And Nadine?
Thank you. Yes, similar to David, I trained as a physician, transitioned my career from clinical practice to policy over a decade ago. And even in the course of my training and education in early years in clinical practice, always had an interest in systems level issues, and certainly in looking at the conditions that really foster health, and having an understanding that those systems entailed certainly access to and quality of health care, but also entailed addressing other systems such as education and economic opportunity, housing, transportation, food security, and had such a passion and interest for addressing health inequities and ensuring that everyone had a fair and just opportunity for health, that I've had most of my career working in the space and in the field of health equity. In federal government, I started as an advisor to the Assistant Secretary for Health, where I had a broad portfolio in environmental health and climate change, adolescent health, global health, and the White House Council on Women and Girls. And so really had a broad public health and prevention portfolio. Where I ended most recently in federal government was as the Deputy Assistant Secretary for Minority Health and Director of the Office of Minority Health at HHS in the Obama administration. And in that role, as Kara alluded to, we had the great fortune to work together, certainly in advancing key priorities of the administration, the implementation of the Affordable Care Act, in particular, our office's role on doing outreach and education to communities of color with regards to the Affordable Care Act and supporting enrollment. As well as implementing the department's strategic action plan to reduce racial and ethnic health disparities and to coordinate a national partnership for action to achieve health equity, in which we worked with partners across the country, community-based organizations, faith-based organizations, universities, and many others to really champion a movement towards achieving health equity.
Thank you. Kind of reminded me of those days of sitting side by side in those swing offices in HHS and the many late nights. But thank you for that. So let's kind of dive in. And you both were there as the Affordable Care Act was being implemented and had really key roles in some of the work. And there's been a lot that's happened since then. But you mentioned where both of you talked about President Biden's administration and some of the work that they're doing, but what do you see as the work that's unfinished with the Affordable Care Act that we need to build on?
Well, I'll jump in. 31 million remaining uninsured. And that's more than was true when President Obama left office. And probably a little less now than those numbers because there has been some increased sign up since the current president took office. But I think that's the first unfinished business. I'd say the second is the equity agenda. It was implicit in the Affordable Care Act, but never explicit. And I think that the assessment of where the Affordable Care Act has fallen short in addressing structural racism and the disparities in care that persist have been diminished, but persist under the Affordable Care Act as a second major unfinished item for the Affordable Care Act.
Thank you. Nadine?
Yes, I would agree with David. I think it was one such excellent news coming from the Biden administration with regards to more Americans than ever being covered by the Affordable Care Act, showing the ongoing need for coverage and certainly the important role that the Affordable Care Act plays with regards to ensuring access to high quality coverage. And I think it certainly importantly is ensuring that everyone has access to high quality comprehensive coverage that assures as well preventive services so that we really can move to having more focus on prevention and well-being. I think too is also the enforcement of mental health parity with regards to the Affordable Care Act, for example, being one of the laws that provided such a great expansion of coverage for mental health and substance use disorder services. But parity and enforcement of parity has been a challenge. And that there's ongoing work there and certainly advocacy with regards to providing federal agencies such as the Department of Labor with the authorities to be able to enforce mental health parity. I think too, the work on equity obviously continues, and the ACA is certainly one of the most important laws that to help to address health disparities. And there are many provisions that we need to continue to further enhance and implement to truly achieve the goals of health equity for the nation.
That's great. And we're going to talk more about equity, and I'm going to drill in a little bit to coverage, but I just want to lift up for a second, Nadine, the mental health parity, because I know that many of our funding partners on today's session and in the conference focus on that. It is an issue that many people are looking at coming out of the pandemic with unmet need. And so could you maybe talk a little bit about why you see that we've struggled to get parity in mental health, and what we could do to move closer to that goal?
Yeah, I think there still is a need for an understanding of how mental illness and substance use disorders certainly are something that are part of our comprehensive overall health and well-being, and that in having access to mental health coverage through the essential health benefits was an important step. And certainly the pandemic, I think, is actually raising awareness and attention to the trauma that so many are facing in the context of whether it's grief and loss, economic hardship, and yet we still have a very much fragmented system when it comes to assuring access to mental health treatment and care. Our organization at Trust for America's Health, we issue an annual report called Pain in the Nation that highlights the rates of drug overdose deaths, as well as alcohol-related deaths and suicide deaths. And what we're also seeing are some concerning disparities in the report that we released earlier this year that shows that for the first time since the early 2000s, that Black Americans actually had higher rates of drug deaths than whites. And so if there's ever a time that in which we really need to focus and redouble our efforts to really shoring up the mental health care system and behavioral healthcare system, and creating integration across the healthcare delivery system and enforcing that parity, it truly is now because of what we're seeing in the midst of this pandemic, which we are still in, and what we will see in the recovery and beyond.
Thank you. So let's talk about coverage. David, you mentioned the 31 million people who are still uninsured for a variety of reasons, and we could talk about Medicaid expansion. Your slide talked about the public health option and feasibility, but there are other considerations that people also have. So what do you think are the ways in which we could close that gap? And I have one question from our audience about, can you envision a politically feasible path to universal health insurance that is fair to people who have low incomes or chronic health conditions? So how do we close that gap?
Well, there are obviously a lot of ways to do it. Our work has shown that there are probably 8 or 9 different finely tuned paths to getting to universal coverage. It can be done based on the foundation of the Affordable Care Act. So I would think that building to universal coverage in the United States starts with building up from the Affordable Care Act. I am not terribly optimistic about a public option. Just today, as a matter of fact, Colorado, the state of Colorado, advanced a health reform bill that eliminated the public option, which had been much discussed in that state. And I still think the forces politically aligned against it are substantial. You mentioned Medicaid expansion. I think the most feasible short-term source of expanded coverage is likely to be the expansion of Medicaid, not necessarily through state action, but through federal action to make a zero premium federal source of coverage available in all states that have not expanded Medicaid. So that essentially people who are eligible for Medicaid could enroll in the marketplaces free of charge and get private insurance. That's a controversial idea, but I think it has the most chance of making the next incremental step. Then there are a bunch of other things to do, having to do with auto enrollment, having to do with increased and more generous subsidies for people who are eligible for ACA marketplace plans that are also possible. It's doable, but it takes political will.
Mm-hmm. Yeah. Anything you'd add, Nadine, to that?
I think David covered it well. Yes.
Okay. So we know coverage doesn't always equal access. So that is, getting people covered is definitely an important part, and it's a first step of getting people through the door. So how do we also improve access to care, considering that we, have a couple decades worth of work from the National Healthcare Disparities Report and Quality Report that shows that we are improving access to care, but we do still see disparities remaining in that space as well. So how do we make better improvements in access, particularly for underserved communities and those in rural and tribal areas?
Yeah, it's a great question. And, Kara, you and I review those reports every year, really in the work that we did at HHS. I think that there certainly have been important gains with regards to access, and there's more that can be done. And I think both in the American Rescue Plan as well as in President Biden's budget request, that there are investments, for example, with regards to community health centers and the important role that they play with regards to underserved and low-income communities, as well as communities of color, and in rural communities with regards to access to care with rural-based healthcare clinics. Certainly shoring up the investment in that primary care infrastructure is important. We also have to look at the base of the types of providers and networks that we have. And so recognizing the importance, for example, of supporting and funding services through navigators and community health workers, promotoras, and others in tribal communities with community health representatives, and the important roles that they can also play in helping to navigate the systems and also helping to assure that not only are our healthcare needs taken care of, but also, and I know we'll get into this, also thinking about the social needs of patients and their families, because those can often be some of the key barriers when we talk about access and quality. It is really important. We also have to look at the systems themselves, and both David and I have alluded to this, that when we look at these disparities, we cannot ignore that structural racism, that discrimination and bias are present in all of these systems and undermine health and well-being. And so where we see, whether it's from philanthropy, whether we see it in health systems, certainly in this past year, especially in the aftermath of the killings of George Floyd and others, the commitment to really look at our institutions and policies and systems with regards to actually dismantling and addressing policies and practices that actually contribute to what may be inequitable care and inequitable quality of care that can exacerbate and perpetuate these inequities. Those two also have to be addressed.
Mm-hmm. Yeah, so let's pivot a little, and I don't know, sorry, Dick, go ahead. You look like you're going to say something, David, go ahead.
Yeah, I was going to say, when it comes to rural parts of the country, many of which have large populations of communities of color, we need to build the institutions, and community health centers are part of that. Fairly qualified health centers are part of that. We need to have broadband accessibility, and there's money in the American Rescue Plan for that, and there's more anticipated in the budget of the president's budget. That can lead to telehealth opportunities. There's one place that telehealth really matters, and that's in rural communities. And it's been demonstrated to be extremely effective, but if you don't have connections, you don't have telehealth. And I think we need to train more people who look like the communities they serve to serve those communities, which of course is a long historic problem in the American healthcare system. And we need to give them the funding and the incentive to locate in those places. The National Health Service Corps could be greatly expanded. The National Health Nursing Corps, less well known, could also be greatly expanded. There's opportunity for physician assistants, nurse practitioners, advanced nurse practitioners to fill in some of these gaps. So a lot of bricks to be laid in this foundation of equitable access. By the way, Medicaid coverage is critical. Rural hospitals are closing throughout the United States because of insufficient funding, and Medicaid would save a lot of them.
We are going to drill deep into rural on Friday as we close out the conference talking about rural health. And I think it's definitely a lot of need there. There's so many directions we can go. I'm going to pivot a little bit to system transformation, but I want to continue with the theme of coverage for 1 second and just think about, part of coverage is also how do we redesign coverage to be better. And so I'm going to combine a question that I've received from the audience with where I was kind of going and building off of something that Nadine, you were talking about in the social determinants of health. And so how do we think about, redesigning our coverage options to better address those social needs? We've seen some gains. Medicaid does an okay job. Medicare Advantage is now providing supplemental benefits for older adults, but we still have a lot of room that we need to do. And in particular, one of our audience members is interested in understanding how we can have our healthcare system be more responsive to the needs of older adults and their family caregivers kind of coming out of the pandemic. And so maybe for both of you, we can kind of dissect that a little bit with the caregivers' needs, but those social needs that really help people age in place, live healthy lives, and achieve their highest level of health. It's a small question.
Sure. And glad we mentioned Medicaid expansion. I think as ongoing work from the ACA is the states that have not yet expanded Medicaid, and there are greater incentives as well to really try to incentivize those additional states on Medicaid expansion, certainly important. I'll start with the social needs and then speak to older adults. So with regards to social needs, Kara, to your point, more and more attention from the healthcare delivery system with regards to social needs and recognizing, when we speak of health, that's such a significant influence on health, or actually what happens outside of the clinical setting, outside of a provider's office, outside of a health system. And so thinking about really these broader community conditions that can promote health or can be barriers to health and create these inequities that we see. So I think this is where I would say, and certainly from Trust for America's Health vantage point, is that partnership between public health and healthcare that can be so vital. When we think about the roles, this is not something that can be done by any one sector alone. These are multi-sectoral issues and challenges, and really need multi-sectoral solutions and partnerships, collaboration. And so we've seen, for example, where health systems are integrating screening and referral into their care delivery models, and with regards to ensuring that we're asking individuals about their food security, asking about housing, asking about transportation and employment and other areas, and not just asking the question, but then being able to connect to the services that are needed, whether those services are based in the delivery system themselves and in the healthcare setting itself, or those are through the social services safety net. And that can be an area where we see partnership between public health and healthcare and social services, community-based organizations, to be able to provide those care and services. One of the concerns that we have, though, is making sure that when those handoffs happen, that public health and the social services, that they actually have the funding and the resources and the infrastructure to be able to meet the need. So that's critically important. And there are models such as, whether it's the Accountable Communities for Health, or systems such as Kaiser Permanente and others that have been implementing these types of designs, I think are really important. And the question is taking it to scale, so that it becomes the standard, so that it can be reimbursable and not be solely what certain systems are doing, but really that becomes the standard of care. As it relates to older adults, that's an area that we are actually also working in as well, that we have an age-friendly public health systems initiative that we are leading in partnership with the John A. Hartford Foundation, in which we're working with state and local health departments to bring a public health framework into aging, because public health hasn't always been at the table when it comes to the issues of older adults, and especially when you talk about aging at home and aging in place. An important part of that is really thinking about prevention and wellness and utilizing this public health framework that has not been there until recently. And so we are now actually doing this where county and local health departments are working on integrating this public health framework to ensure that older adults actually can age healthily, giving them the resources and tools to connect the aging sector with the public health sector. And then in the midst of COVID-19, even thinking about some of the challenges that exist, for example, with regards to homebound older adults or those with disabilities, to assuring that services are being reached to them as well, so that it's in-home services, that it's services, again, from trusted community partners to be able to meet their needs, again, so that they too can live healthy lives as older adults.
Thank you.
I just like to, I agree with everything Nadine said. I would also like us all to be aware that there's only so much the healthcare sector can do to correct the centuries of racism and deprivation that we're living with, and that housing, education, childcare, perinatal care, these are and care for the homeless, for the homebound. These are all essential public services that, in the end, should probably not be the domain of healthcare. Healthcare can make a contribution, and one way to encourage that is to adopt more prospective payments so that the healthcare institutions consider and have the flexibility to consider investments in services that reduce their costs and improve the quality of care because they're incented to do so. And that's a common denominator of many of the organizations that currently are exploring these social determinants as investments. But ultimately, it's who votes, whether a budget like that the president has put forth has a chance of passage, and whether comparable investments occur at the state level. This is about much more than healthcare.
I couldn't agree more. And a question that is constantly coming up of what is the role of the healthcare system in addressing the social determinants? Why, one of those questions, we have a Department of Education, we have a Department of Labor, we have a Department of Housing and Urban Development, and yet we are looking more and more to HHS to address a lot of these issues. And Nadine, as you were talking about some of the work in homebound older adults, and not even just older adults, but of course equity comes up in that as well, because that lifetime of sort of poverty and challenges and discrimination that have led to the income disparities that we see results in older adults having huge gaps in the median savings that we see by race and ethnicity. And so it makes me think about those out-of-pocket costs and what that means for your ability to age in place and age at home. If you have an income or savings that are only about $14,500, which is what it is for older Black adults, and about $10,000 for older Hispanic adults, compared to median savings of $118,000 for older white adults. And one of the questions that we have in here when we think about those out-of-pocket costs, particularly for people with multiple chronic conditions, is the cost of prescription drugs. And this is something that was a focus in the previous administration. And so one of our audience members wants to know, it's still a bipartisan issue. Do we think that this will remain on the agenda for federal reform in terms of prescription drug costs? So that for either of you to try and address.
Well, wandering into drug policy is hazardous. I'm somewhat still stunned by the approval of the Alzheimer's drug today, another topic. But surely there is bipartisan interest in controlling drug prices because there is huge voter interest in that topic. The obvious and probably most effective approach would be to follow the pattern that was outlined by Speaker Pelosi, and in terms of regulating the prices using an international reference price, if that's one approach, to the most costly and commonly used Medicare drugs. Those prices would then quickly be emulated in the private sector. That would be very direct and very effective. I have trouble seeing that emerging from our current narrowly divided Senate, and especially as we get closer to the 2022 midterm elections. One of the things that I think is less well explored, but something we've been doing a lot of work on, has to do with the source of the ability of drug companies to set their own very high prices. And those have to do with the patent process and how the patent process is funded and organized and executed. And I think there's a substantial agenda that the Congress could take up that has to do with eliminating abuses of patenting that many drug companies engage in, that basically give them 40, 50 years of patent protection instead of the 20 that is normally provided. And they do that by filing frivolous patents that take decades to overturn. So there's a lot that can be done. There are some obvious things to do. They're politically difficult. They would work. They'd save hundreds of billions of dollars. They would enable us to invest in some of these other things that we've been talking about. But it requires a different constitution of our national representative bodies.
Thank you. So let's go back a little in the system transformation space. So David, this is work that you guys spend all day doing at the Commonwealth Fund. And so as we're looking at where our system needs to go and how we build a more just and equitable future, what in your mind are some of the top changes we need to see in our system in order to get there?
Well, at the risk of being repetitive, perhaps to an extreme, the first and most important thing is covering everybody. There's no such thing as a fair and equitable system without insurance. It's not enough, but it's an absolutely essential component. A second is for the healthcare system to address directly and consciously the sources of systemic racism that permeate the healthcare system. And that is something that has its own set of policies that we are working on internally at the fund. A third is a whole set of ideas related to delivery system reform that require or amount to increasing the accountability of actors in the healthcare system for the behaviors and results that they get in the process of providing care. That goes under the title of value-based payment often. This administration seems to be continuing the commitment of the last two administrations to increasing value-based payment. I think that term is getting a little bit vague and difficult to define. So I prefer to talk about accountability, with payment being one way of assuring accountability. With respect to equity, I think there's an agenda for paying for equity that has not yet been constituted or developed, that I would like to see some more work done on, and I think that's on the agenda of the administration. Paying for quality or prospective payment that includes quality accountability is another, I think, way of moving forward. So delivery system reform is part of this as well. We have a very complex, fragmented healthcare system, creating loci of accountability and then creating systems for holding those actors accountable is a very important piece of the agenda.
Nadine, is there anything you'd add?
Well, one ask is if I can speak to the system that in particular we address, which is the public health system, or if you'd like to do that later, because I think that there certainly is the intersection, right, with the public health system, and certainly we're at such a critical moment for the public health system, which has been just chronically underfunded and under-resourced and staffed for decades. And as we've been talking about within the context of the pandemic, it highlighted and demonstrated that under-resourcing. It also highlighted and exposed certainly and has worsened the disparities that we've been grappling with as a nation. And so I think importantly, it's the investment to actually build this modernized public health system that is an effective system to be able to really respond to an increasing number of public health crises, ongoing day-to-day public health needs, and where we've seen such variation across states and local public health departments that really, because of the lack of investment in them, have had challenges with regards to meeting the core foundational capabilities, issues like assessment, where they're able to track health threats. And so thinking about surveillance systems and data, to having an all hazards preparedness. We've cut, federal funding has been cut to emergency preparedness programs over the past decade. To communications and having effective communications that can reach diverse audiences, to the types of partnerships that need to be built, certainly to advance equity, as well as policies and organizational competencies. So that then gets to the workforce, because we've also seen a reduction in the state and local public health workforce, and really training a workforce. It's hard to hire and recruit, hire and train and retain a workforce if funding just is cyclical, or it's so categorical that it's hard to be able to maintain that workforce that's able to meet all of these growing health demands and needs. That is certainly an area that we need to focus in on, and shoring up the data structure and really using evidence-based approaches with regards to our public health work on a day-to-day basis, as well as what is done in emergencies. And then centering and prioritizing equity. And we've seen that commitment certainly from the Biden administration through an executive order on day one with regards to addressing racial equity and the needs of underserved communities, that must be sustained. And really it's for all of us to be engaged in, and public health has a role there to play as well. When we look at the response and recovery from this pandemic, that equity really has to be centered in all that we do, in the data, in the partnerships, in the resources that are going to community-based and faith-based organizations and other trusted partners in communities to work alongside public health to be able to meet the needs of communities. The challenge has been, again, the funding and the resources that they're not sustained, they're not at the level that they should be, and so assuring that we have that in place. And then lastly, I'll say is really addressing the social determinants of health. As David said, healthcare cannot do this alone, neither can public health. And so the ability to be able to work across sectors, one, it takes building those relationships, sustaining those relationships across sectors, being able to speak the languages of other sectors and identify shared priorities. And there hasn't been, specific funding specifically for public health to work on, have a workforce that addresses the social determinants of health. And that's what makes these investments that are proposed in the budget, that have been proposed through the American Rescue Plan, so important to build that capacity to actually address the social determinants of health and work with other sectors such as housing and transportation, education, and others to really get upstream. We really need to think about how do we actually create healthier and resilient communities, as opposed to solely being reactionary to when there's an emergency or seeing the high rates of chronic illness that need to then be treated further downstream.
So you've mentioned trust. We had a plenary earlier today that focused a lot on trust-based philanthropy. We've talked about sort of the healthcare system, the public health system, and communities. And I would say probably the healthcare system doesn't have a great record of working with community to address needs. So as we think about this, how do we engage community and build that trust to address a lot of the challenges that we are talking about?
Nadine, that seems...
I'm happy to start. Yes. So I think a key lesson is actually trying to build those relationships before the emergency and crisis happen, right? To have those relationships so that when the emergency and crisis happen, there are existing relationships and that can be leaned upon to address the needs of communities. It takes time. It takes true, authentic, and meaningful engagement, where it's recognizing that communities have assets and they have trusted leaders, organizations in those communities. It's meeting communities where they are and looking at one's own infrastructure, organizations and institutions, and asking, do they have a voice in the planning, in the decision-making, in the evaluation of whatever systems are being designed or practices and policies are being put into place. So that's inclusive of, having, for example, advisory committees that are representative and inclusive of those community members and those with lived experiences. That's ensuring, for example, that our boards and governance and leadership, as David noted earlier, really represent and are reflective of the communities that are being served, and having a way in which accountability, it's important that we are gathering data and disaggregating data by race and ethnicity and socioeconomic status, disability status, and a whole host of other demographic factors. But we have to then use that information to actually lead to the type of interventions and supports and systems that are going to then provide equitable access and inclusion of communities, and not doing for the communities. I think it also requires investment too, so that many of these trusted organizations and entities have not gotten the resources to be able to do the critical and important work that they do. That's from the, at the federal to state and local level, as well as the private sector is actually also investing in communities, because for so long, these communities have been marginalized, they have been disinvested in. And so to really build trust will take that time. And we at TIFA hosted a policy convening on building trust in the COVID-19 vaccine, for example, and equitable access to the vaccine for communities of color and tribal nations. And we brought together civil rights and public health and health equity and healthcare organizations, government officials. And it was just clearly recognized that we had to utilize the assets and the trusted members in the communities, have them from the beginning through to evaluation, to be able to really assure that we're building the foundations of trust, but recognizing trying to do it at the same time that you're trying to do vaccine delivery, for example, can be very difficult.
Yes. So we are quickly run. Oh, go ahead, David.
I was going to come back to something that Nadine said about leadership, boards, executives. We're talking about the delivery system now. It is a lot to ask people who have never related to communities and have no feeling for them to become trusted ambassadors to those communities. I think the solution to that problem is to have people that represent those communities, that are of those communities, in leadership positions in healthcare organizations. And to the extent that we're talking about delivery systems, which are the front line of many communities. So making sure that boards are diverse, making sure that the C-suite is diverse, and making sure that the staffs of healthcare organizations are diverse is, I think, a foundation for trust and for effective partnerships with community-based organizations.
Absolutely. So we are quickly running out of time, which we knew was going to happen, but I'm going to try and hit on two quick things. So I'm going to give you a preview of where we're going to end. I want to end with advice that you have for our funders in how to engage with the government on these topics. When we surveyed our funding partners towards the end of last year to ask about areas and work that they were doing, a number of them said that they were shifting to system change, thinking about advocacy and education. So having been in the role of a federal employee engaging with stakeholders in a variety of spaces, what advice do you have is going to be our ending question. And I want to kind of touch quickly on something that, both of you have mentioned, and David, you just talked about in terms of diversity, but also pathways. We have workforce shortages in mental health and in other spaces. We have burnout from our providers who have really been challenged, not just in this past year, but even dealing with opioid epidemics and other spaces, our public health providers. So how do we create those pathways both to ensure that we have the workforce necessary to address our needs going forward as a country, but also to ensure that diversity, to make sure that we have different perspectives at the table and respected?
Well, we have to start by educating at the most basic level, equitably and fairly. And then we have to make sure that mentoring and sponsoring are available to all professionals, including people of color. And I think we need to have dedicated programs designed to create leaders who represent communities of color. At the Commonwealth Fund, we've long had a minority health policy leadership training program. I'm sure you all have worked with a number of our graduates. We now have programs at both Harvard and Yale, and we have 120 or 130 graduates of the program who are now, many of them, leaders in public and private organizations. So I think that's one pathway, and I think doing that on a much larger scale would be helpful, not sufficient, but helpful.
I agree with David in that it's both thinking about those who are already within the pathway that you can continue to help support, mentor, provide opportunities and exposure to the various career pathways that are ahead. But then it's also thinking longer term and really thinking as early as possible with regards to our youth and young people. And Kara, your question reminds me of, as you'll remember, an initiative of the Obama administration was, and that continues, is My Brother's Keeper, in recognizing that there were persistent opportunity gaps, for example, for boys and young men of color, and how do we address those opportunity gaps? And one way, this again is a way in which we in public health worked across sector with education, was recognizing the disparities as it related to suspensions and expulsions that were happening as early childhood education, and in which youth of color, and in particular Black boys and girls, were being suspended and expelled as early as preschool at higher rates. And that already was setting them on a path that was inequitable with regards to educational attainment, economic opportunity, et cetera. And so it's really looking at, again, those types of root cause systems and policies, the biases that exist there, the structural racism that exists there, to be able to use our voice, to use the data to actually try to change practices and policies that are disproportionately impacting, for example, youth of color, youth with disabilities, et cetera, so that we can create this pathway for young people to pursue these types of professions and mentor them through it, support them through it, and address certainly the various barriers that exist through that pathway.
Okay. So as you guys are gathering your thoughts for the what we can do, tips for philanthropy in this space, I have two quick questions for you, Nadine. One easy one, and one that might take a little more thought. And the easy one is there's been a request for the graphic that you shared at the beginning, and wondering if that is something we can make available to our audience. And the second one is building on a pandemic lessons that we've learned related to public health's political savviness. Are there ways that public health can ensure it's at the table regardless of who's in charge in terms of major parties?
So yes, easy question. Yes, so absolutely, the graphic is available, and there's something designed with our partners at the Beaumont Foundation, in which we were talking about social need versus social determinants of health, and have written about that. So happy to share that as well. With regards to public health and political savviness, I will say, to taking a step back, it's also how we remove politics from public health and science. We saw and are seeing the challenges that public health has faced, local, state, federal levels, with regards to being questioned on decision making, being removed from decision making, really when these efforts are being made in the public's health. One of the initiatives that we launched in partnership with the CDC Foundation and the De Beaumont Foundation is called the Public Health Communications Collaborative, which was designed to help support state and local public health officials in messaging and in addressing tough Q&A and knowing how to be able to address things that could be controversial, but more so are controversial, for example, because of the partisanship or political nature that is being infused into the dialogue. I think that skill that you're talking about with regards to communications, that's one of those core public health foundational capabilities that we're speaking of. And that's what makes the long-term investment, what has been done with regards to investment in public health infrastructure through the American Rescue Plan and what's proposed in the president's budget, critically important. We need to continue that and sustain that in the long term. And there are legislative efforts such as the Public Health Infrastructure Saves Lives Act that Senator Murray has introduced to shore up and provide what we find as a shortfall of $4.5 billion every year for public health's core functional capabilities. And that includes the communications, the leadership, and the ability. But I think we too need to recognize that elected and appointed officials, there's a core role that they play with regards to these decision-making abilities. And what's concerning us now is that there are ongoing efforts now to even reduce emergency powers and authorities of public health. And so that's something we need to be aware of and something to use our voice to assure that public health has that seat at the table and can do what's right in the public's health.
Thank you so much. Okay, so David, what is it that philanthropy can do to work with the federal government? And we didn't even get to talk about state partnerships, but to build a more just and equitable future and also improve our healthcare system, making sure that everyone has coverage and access to care, high quality care as we talk about.
There are some of your members, I suspect, who have 501c4 or lobbying arms, and they can directly advocate. There are others like us who may feel uncomfortable with direct involvement with policy work. We don't shy away from it. We embrace it because we believe that there is a very robust discipline, scholarly discipline, that has to do with understanding the implications of policy initiatives, and that results of that work need to be available to policymakers. So we support work on policy analysis, and then we make it available, we try to make it available to key decision makers. And I think our mantra is the right information at the right time to the right people in the right way. And each one of those is critical. I can tell you, when I worked on Capitol Hill, when I worked in government, the same information delivered at a different time might have no influence than when it was delivered when I faced a decision that I had to make. So timing is critical. That means familiarizing yourself with the rhythms of policy and government. And this is true at any sector, whether it's the state level, the municipal level, or the federal level. Is it on the agenda? Are people's ears open? Do they have to confront it? If so, there's an opportunity. And then making sure that the information is consumable and understandable by lay people, because lay people are making these decisions. Now, that's not always true in the public health departments or the Department of Health and Human Services, but there are a lot of people, especially at the state level and even in federal employment, who are not very sophisticated about the policies they're tasked with taking on. So making sure it's understandable. Pictures are very helpful. Infographics instead of long streams of data. And then just finding the right people. Who is it that actually is controlling a decision? Which are the congressional committees of importance? Which are the members on those committees that are important? Which are the staff people working for those members who are important? These are all things that are knowable to philanthropies and don't entail lobbying, just entail what we are tasked with doing, which is developing information and communicating it. But communicating it strategically, the strategy is incredibly important. So I think we can do a lot, but we have to be smart about it.
Thank you. Nadine, last word to you.
Yes, just quickly, I will say I support what David has said and helping to make that connection, just expanding on what he said with regards to making that connection between health and what may be other sectors and the implications of that. The research that can be developed, the analysis that is not directly addressing a specific bill that is under consideration, but making the connection, for example, between housing and health, making the connection between economic opportunity and health, those kinds of areas in which we can further explain why why decisions in those sectors do have implications for health and well-being, I think really are powerful mechanisms from philanthropy, and certainly partnering with other organizations that then may do this work certainly is another way in which, and we certainly have done that at Trust for America's Health, is another way in which I think philanthropy can be engaged.
Thank you. And the only thing I would add is for not always to think about just the politicians who are making decisions, because as we see with a lot of the bills that are passed, it's the agencies that are actually tasked with implementing those, and you'll see rules, regulations, and the program guidelines that come out from there. So thinking about those career staff who are actually the ones putting the meat on the bones, as we say, about the policies that are passed. David, Nadine, I want to thank you both for a rapid fire tour of a short part of our health and healthcare system opportunities, and for sharing your knowledge and your wisdom with our audience. There's so much more we could have covered. We'll have to invite you back for another conversation at our conference next year. And this closes out that section and also ends our first day of our annual conference. I hope that you will join us tomorrow starting at 1 p.m. Eastern Time as we kick off with a plenary session with Dr. Marcella Nunes-Smith on centering equity in the pandemic response and recovery. We have additional breakout sessions, network sessions, and another plenary session to end the day on reprioritizing public health. Again, I thank all of our speakers today in the plenaries, the breakouts, and hope you have a good evening, and we'll see you tomorrow. Thank you.